Okay, we are live, and good afternoon, everybody. I'm Alan Tay, aka Kertua Dobbs, and welcome to SJMC Cardiology Grand Rounds number 18. 18 since the pandemic, which is excellent. I just want to go through some housekeeping slides before I pass on to the moderator for this session, who is Dr. Kanan. And if you're watching this from YouTube, if you want to be notified of our upcoming CPD webinars, please feel free to subscribe and hit the notification bell. All right. So now our Q&A will be at the end of the session, and we prefer if you use Slido. So if you're watching it in the main Docs web page, you realize there's a Slido at the bottom, okay? Or else you can go to slido.com and enter the code 893451, and that will be the code which will take you to the Q&A page, okay? And as usual, this session, you can claim a CPD point, and we'll display a QR code at the end of the everything, and you can scan with the MMA app to claim your CPD point. Okay. All right. Now, without further ado, I'm going to exit and pass over to the moderator, Dr. P. Kanan, and happy listening.
Hi. Good afternoon, ladies and gentlemen. This is Darth Vader here, as you can see from my mask. For April and May, we have chosen to discuss a very common arrhythmia, atrial fibrillation. We will be presenting cases that we have managed in our hospital, and to help us answer many questions will be our two brilliant electrophysiologists, Dr. Choi and Dr. Koh. And let's get going. We'll start with Dr. Koh. Dr. Koh, can you please enlighten us as to what is atrial fibrillation and what are the common causes?
Sure, Dr. Kanan. So I thought it would be easier to share a video and to educate our audience what is actually atrial fibrillation. Now let's start with the normal heart first. As we all know, the atrium and the ventricle, they pump in synchrony. The upper chamber pumps to the lower chamber. The lower chamber, which is the ventricle, pumps to the rest of the body. Now, this when you feel the pulse, you'll feel a very regular, steady, uniform pulse rate and volume. Now, this is all governed by our sinus node, which will act as a pacemaker, and then it travels to the both atrium. Later on, we'll go through the AV node, which will slow down the rate a bit. That's why we have a PR interval that is about 200 milliseconds and below, and then goes to the ventricle and then pumps out. The problem in atrial fibrillation is there is no steady rhythm. All right, there is no steady rhythm, and most of the time it's just an erratic, chaotic rhythm of the atrium. They just quiver and shiver, like you see in the video, and this causes the atrium has no atrial output, loss of atrial kick, and because of the atrial fibrillation is so fast, almost like 400 to 600 beats per minute, it causes the ventricle to contract erratically and not in sync, and this causes a lot of problem to us. Now you can see that most of the trigger coming from the left atrium in the atrial fibrillation. Okay, next slide please. So there is a bit of illustration on what is atrial fibrillation, so you can see, and a lot of things that we don't know about atrial fibrillation, but what we know that a lot of this atrial fibrillation is attributed to aging. If you are elderly, more than 75 years old, 1 out of 4 people who have atrial fibrillation. We know that the non-Caucasian has lower risk than the Caucasian of having atrial fibrillation. Being a male sex is higher risk of getting atrial fibrillation, and some genetic defect prone to get atrial fibrillation. We also found that a lot of associated to developing atrial fibrillation, and it's very important for all of us, the doctors, especially when we see the patient who has atrial fibrillation for the first time. We look for all the potential modifiable risk factors first, like how we treat our usual patient with coronary disease. We look for all these risk factors. Now, just look at maybe we start from 5 o'clock, the obstructive sleep apnea, especially with young patients. Nowadays, I see a lot of young patients with atrial fibrillation. The first thing I need to screen is whether they have any sign and symptom of obstructive sleep apnea. And some of them, they might not even know. See the ENT or the respiratory physician to do a sleep study to make sure they have no obstructive sleep apnea. Because in young patients, it's very unusual for them to have AF at a very young age. Now, obesity is also linked with atrial fibrillation. As you go on, you can see that smoking, alcohol consumption, all these things, as a doctor, we can actually identify very early and modify the risk. Of course, some of the risks you can't modify. For example, if the patient have a severe valve disease like mitral stenosis, patient already have a pre-existing coronary disease, especially post-myocardial infarction, they are prone to get atrial fibrillation. Other than that, like diabetes, hypertension, cholesterol, make sure the patient exercise, all these are potential modifiable risks, and all of us actually can take part on identifying this and try to reverse it. Sometimes the AF may just come once, and after modifying the risk, they may be suppressed for a long period of time. So I think that's the brief introduction of what is atrial fibrillation and what are the common associated risk factors for atrial fibrillation. Kanan, back to you.
Okay, thank you. Thank you, Dr. Cook. Dr. Choi, perhaps you can tell us what you would look for in an ECG that shows atrial fibrillation, which may show us what is the underlying etiology.
Okay, thanks for the Kanan. So just like any other ECGs, it's actually an art when you look at an ECG with atrial fibrillation, other than whether this is AF or not an AF. But I would say that we can try to look for the etiology. For instance, if the patient has ischemic heart disease as a cause of AF, you can, okay, let's look at this ECG. So this patient's ECG obviously has atrial fibrillation. It's irregular, it's fast, and you can look at the voltage criteria. It's possibly LVH in this patient. So that kind of like gives us a clue that probably this patient has hypertension as a cause of the atrial fibrillation. Other features that you can see here will be interpolated broad beats, which commonly seen in most of the AF as well. These are all the PVCs. Also, maybe the patient has some kind of ischemic heart disease as well. Maybe we can go to the next slide. And this is another ECG that shows atrial fibrillation. Okay, sometimes when you look at a very fast atrial fibrillation, it appears to be SVT because it can be quite regular, as you can see on this ECG. But if you look at it really carefully, you can see a little bit of irregularity. So that tells us that there's no P waves, it's slightly irregular. So it's more towards atrial fibrillation than SVT. And this patient also has right bundle branch block. Sometimes right bundle branch block can give us a clue. For instance, if a patient has a right atrial enlargement, right ventricular hypertrophy, pulmonary embolism, pulmonary hypertension, that could be a cause of his atrial fibrillation. Lastly, maybe the next ECG can also tell us a clue. So this is actually the ECG post-reversion of the atrial fibrillation. So you can see the right bundle branch block remains the same. So it tells us that sometimes the RBBB that you see during an AF is actually not rate related. And the QT interval is quite important as well in treating a patient with AF, because if the QT interval is prolonged, then probably amiodarone is not the best choice of treatment for that particular patient. So I would say these are the few features that we see for TG AF. Yeah.
Thank you, Dr. Choi. Dr. Koh, back to you. What are the consequences of atrial fibrillation?
Okay, maybe let's back to the video. Now, we know that if we live, we are all born with sinus rhythm, so atrial fibrillation cannot be good. So imagine that our atrium is beating very fast at the rate of 400 to 600 beats per minute. In fact, it shivers, it doesn't even contract. You can look at the atrium, it becomes more fibrotic. It becomes structural incompetence, and it enlarges. The atrial enlargement often cause something what we call heart failure symptom, especially diastolic heart failure or heart failure with preserved ejection fraction. Later on, the LV, the ventricles also will enlarge, causing reduced ejection fraction. So heart failure is one of the common consequences. And of course, the one that we all fear is because the blood is stasis in the atrium during atrial fibrillation, the tendency of developing blood clot in the LA appendage, as shown in the video, is very high actually. And if you are unlucky, these LA clots, the left atrial appendage clots, can dislodge, and then the ventricle will pump. Usually the first organ to get affected is the brain, because it straight away pumps up. And sometimes it will go down instead, and it can cause a lot of problems like mesenteric ischemia, renal artery thrombosis, and Dr. Kannan is showing something very gross. Dr. Kannan, is this your patient?
Yes, this is a gentleman who had dilated cardiomyopathy with atrial fibrillation. He was started on warfarin, and then he defaulted follow-up because of the COVID pandemic, and he turned up about 9 months later with what you see here, gangrene of his toes. And our vascular surgeon, Dr. Liu Ngo Chin, went in and fished out this long thrombus. And the man was quite lucky, because instead of losing his whole left lower limb, he just lost his toes, and he's still able to walk. I hope he has learned his lesson.
Yep. I think most of in our ER, I mean everywhere, if you observe a patient that comes in with a stroke, ischemic stroke, I think almost 20 to 30%, they probably have the underlying undetected atrial fibrillation. Yeah. And we know that the burden is very high. For those who have cardioembolic stroke, we know that the morbidity that they suffered from cardioembolic stroke is greater than those with just atherosclerotic occlusion, because cardioembolic stroke is usually very huge. They affect a large territory. They often comes in with a hemiplegia, dense hemiplegia, dysphagia, and they are able to take care of themselves, and they rarely recover from it. So yeah, this gentleman is quite lucky, just losing part of the foot.
Okay, we'll move on. to Dr. Choi. Dr. Choi, should an attempt be made to reverse atrial fibrillation to sinus rhythm in every patient? In which patient or patients would you endeavor to maintain sinus rhythm?
Okay, so as AF may lead to risk of heart failure, not to mention it also causes shortness of breath and may limit the functional ability of the patient. And also AF begets AF, meaning that the longer you leave the patient in AF, the more likelihood of the patient developing persistent AF in the future. So I would say that generally we should try to reverse the EF rhythm to sinus rhythm in most patients, especially in patients who are at the early stage of atrial fibrillation, smaller left atrial size of the heart, with good reversible causes. When you look at this slide, there are a few causes that can be reversed. At least cardioversion, if not ablation, as treatment options. However, not every patient, I guess, can be attempted. Some patients come in late, hugely enlarged left atrium with non-reversible causes, then perhaps a rhythm control might not be the ideal way in treating them. And coming back to the second question, in which patients would you endeavor to maintain sinus rhythm? I would say patients with heart failure, to be precise. Anyone who has heart failure, especially because of AF, we should try to keep them in sinus rhythm as much as possible, as these are the highly symptomatic patients. If the patient has mitral valve disease, classically, those with mitral stenosis, I think because they rely a lot on the atrial kick, which is the last diastolic filling phase of the heart. If you lose that atrial kick during atrial fibrillation, these are the group of patients who will go into heart failure rather easily. So anyone who's symptomatic or anyone with heart failure, I would say we should keep them in sinus rhythm.
So in a nutshell, if someone has had atrial fibrillation, which is of relatively recent onset, you will do your utmost to maintain them in sinus rhythm. But if someone has presented with atrial fibrillation, which has been there for a very long period of time, especially if there has been underlying structural heart changes already, then you just go for rate control. Would that be right?
Yeah, that would be my strategy.
Thank you. We'll go on to the first case. The first case is a 75-year-old lady. Her husband has been my patient for about 20 years. And for a long time, she would just accompany him. This time, she turned up for her own consult. She had had labile blood pressure for a few years, but people told her family physician said no treatment was required. Recently, however, she noted that her systolic blood pressure readings at home had gone up to about 150 millimeters of mercury. She was asymptomatic. She exercised regularly. There was no history of diabetes. She never smoked, never consumed alcohol. In the past medical history, she was told to have a small hole in the heart. Clinical examination revealed a thin, small lady. The pulse rate was 80 per minute, regular. Of note, the thyroid was not palpable. Blood pressure in the both right and left limbs were 180 by 110. I noted that the heart was enlarged clinically because the apex beat was located in the fifth left intercostal space on the anterior axillary line. However, clinically, there was no left ventricular hypertrophy. In the mitral area, a grade 2 by 6 systolic murmur was heard, and the rest of the examination was normal. This was an ECG, and Dr. Choi, could you please interpret it for us?
Okay, so although we see this is an ECG in sinus rhythm, this patient, and you can see right bundle branch block appearance on this ECG. And although RBBB can be quite common without any remarkable clinical findings most of the time, because it's idiopathic, and we can leave them just alone. But in the patient with history of palpitation and possibly atrial fibrillation, RBBB can be a sign of a right-sided heart strain. So you look hard for right ventricular hypertrophy, you look for right axis deviation, maybe enlarged P wave like P pulmonale or mitrale to indicate atrial enlargement. But in this case, I don't think so. To me, it's just a simple right bundle branch block, sinus rhythm. At most, it's a first degree AB block, first degree heart block. That's all for this patient.
Thank you, Dr. Choi. Now, this is the chest X-ray of this patient. Dr. Choi, can you comment on the chest X-ray?
So I totally agree with you, Dr. Kannan, when you examine and you find the apex speed to be deviated. To me, the cardiothoracic ratio, as how we interpret X-rays, seem to be increased in this patient on this projection. The left atrial border seems to be enlarged as well. Probably the patient has left atrial enlargement, and there's no significant congestion seen this particular X-ray.
Okay. So if you look back on the ECG, there's no evidence of left ventricular hypertrophy. Would you agree with me, Dr. Choi?
Yeah, on this ECG, not much. I don't think there's any left ventricular hypertrophy changes.
So we went on to do her echocardiogram, and we were quite surprised to find that the left ventricular size was normal. There was no left ventricular hypertrophy. The ejection fraction was very good. And as you noted on the chest X-ray, there was some dilation of the left atrium. There was small ventricular septal defect, and there was mild mitral regurgitation. These findings were reproduced in another different medical center, well known for echocardiogram assessment. So we started treatment for her blood pressure, and we noted that she was very sensitive to medication, and the blood pressure would just come down with just low doses of medication. And finally, just felodipine 2.5 and valsartan 40 milligrams per day control the blood pressure. She remained well on treatment, and about a month later came for a routine follow-up. Her blood pressure was 140 by 80 in my clinic, but she said that her readings at home were lower. But what was interesting was that although she was asymptomatic, I noted that her pulse was completely irregular. I did an ECG for her, and Dr. Choi, can you interpret the ECG first?
So this is the second ECG for the same patient, and consistent with your clinical finding. So this ECG shows irregular rhythm. There's no P wave seen, and can all agree that this is atrial fibrillation. The RBBB remains the same. There's no further changes. We know this is part of the old findings. The rate Y seems to be quite well controlled, the average rate. So I would say it ranges between 70 to maybe 90 for this AF. Quite importantly, the QTC, the QT interval for this particular patient, which is a bit difficult to measure because the R to R intervals are varying all the time. But eyeballing wise, I would say it's still within normal range, but probably towards the longer end. So if you were to put her on an immunodiuretic, you have to be a little bit more careful, just in case you get a bit of hypokalemic induced toxicity point.
Thank you, Dr. Choi. Dr. Koh, usually, from what I know, the ventricular rate is fast in atrial fibrillation. Two questions to you. Why is the ventricular rate usually fast in atrial fibrillation? And then, why is the ventricular rate not fast in this patient?
Very interesting question. Maybe you show the next slide. You are right that most of the time the ventricular rate is very fast. And why is it so? Now look at the diagram on my left side, the normal conduction system. As I illustrated earlier, that most of us have a sinus node, which is our pacemaker node. Every time when the sinus nodes fire, it will conduct through the ventricle via the AV node. Now this AV node acts like a toll gate, like our plus toll. Why? Because most of the time in resting state, if our heartbeat beat from 60 to 100 beats per minute, the AV node will be able to allow all the conduction through the ventricle. Means that if the atrial beat at about 100 beats per minute, the ventricle will contract at 100 beats per minute. If the atrial rate increase at resting state, meaning that not exercise, for example, in cases like atrial flutter, supraventricular tachycardia, the AV node may not allow excessive conduction for the atrium because it's like a filter. Imagine that if in the flutter your heart beats about 300 beats per minute and it conducts to the ventricle at 300 beats per minute, every time you get a flutter, the patient will get a cardiac arrest. So the AV node is like a safe keeping. So it will not allow excessive conduction. So it will allow maybe about 150 beats per minute and then it blocks. So every 2 conduction from the atrium, it will be blocked once. However, in atrial fibrillation, the atrial rate is very fast. In fact, it's just quivering around, but there's a lot of small chaotic electrical activities, and it contracts about 400 to 600 beats per minute. And the AV node itself sometimes filters all this, but it cannot filter everything. So in a normal state, especially those who presented very young age, presented with the first time with atrial fibrillation, the ventricular rate are usually very fast. It will conduct up to even 200 beats per minute. All right. However, in this case, why the ventricular rate is not so fast in this patient? There are several reasons. Number one, perhaps the patient, you look at the age, is about 75 years old. Most likely at this age, sometimes the AV node has a bit of AV node disease, and it is a common association with a patient with atrial fibrillation. Number two, the VSD probably have some related association. For example, the RV, the RA, the LA perhaps dilated, stretching, caused by the VSD, stretching the AV node. That's why the AV node also a bit slowed down in this case. And maybe not in this patient, in some other patient, perhaps there might be other underlying medication that slows down the AV node. For example, like beta blockers, calcium channel blocker, digoxin, amiodarone, so on and so forth. And sometimes, if you leave the AF long enough, the AV node become fatigued. You know why? Because it's like you're banging the AV node like 400 and 600 beats per minute. A lot of time, the AV node are in, we call it the relative refractory period. Just imagine you're in the toll and you're alone in the toll gate, and suddenly there's a lot of car. Initially, you're trying to clear up the car, but after a while, you become fatigued. You just, okay, just let the car all line up and jam it. So something like that, I make it quite simple for you all to understand. So, very important also to make sure when you start any medication, AV nodal disease, you make sure the resting heart rate during atrial fibrillation is not too slow, because if you get even slower, it's very difficult to get it up. All right.
Okay, thank you, Dr. Koh. Let's move on. So, is there a role for negative chronotropes like
Good.
beta blockers in the treatment of this patient?
So in this patient, definitely not. So, but I would like to show you a snippet of the guideline from the ESC 2020. Can you show the next slide? Now, if we have a patient with atrial fibrillation and we think that we want to rate control the patient first, so number one, of course, make sure the heart function is normal. So if the heart function is normal, then any medication can be used. For example, beta blockers, daltism, or verapamil are good in controlling the rate. But then you're going to ask the second question: what heart rate are we looking at? Now look at the fourth row. It stated that a resting heart rate of less than 110 beats per minute, which is the linear rate control, should be considered as the initial heart rate target for rate control therapy. And all this rate is probably from the historical trial. I don't know whether Dr. Khan remember the race 1 and the race 2 trial, something like that. They talk about the linear control and the strict control. So if you have a resting heart rate of less than 110 and the patient doesn't seems to feel anything, like this patient is asymptomatic, perhaps there's no role for beta blockers or verapamil in her case.
Thank you, Dr. Koh. Does this patient need anticoagulation? If you think that the patient requires anticoagulation, how would I determine the need to start anticoagulation in this patient?
Okay, very important question. In fact, this should be probably the first question to start off with when we see a patient with atrial fibrillation. When we see a patient with atrial fibrillation, it's not whether the rate or rhythm control first, whether the patient need protection from stroke. Now, how do we determine that? So there's a very simple guideline widely used, which is called the CHEST score. You can see that on the right panel, there's all the risk factor in the CHEST score. The C stands for congestive heart failure, or LVEF less than 40%. In fact, Dr. Kannan, nowadays we even include heart failure with preserved ejection fraction in this risk group. Number two,
Okay.
the H stands for hypertension. And number three, if your age is more than 75, you are at very high risk. That's why we see that the score there is 2. Diabetes, score 1. And if you have a history of previous stroke, TIA or peripheral vascular disease, thromboembolism before, then you score 2, very high risk of getting another one. And vascular disease, which either you have a myocardial infarction before coronary disease or peripheral vascular disease, score 1. And you are age between 65 and 74, then it's score 1, female 1. So in this lady, we have evidence that the patient have hypertension. So 1, patient is 75 years old, 2, so 1, 2, 3, female 4. So you have roughly a score of 4. So if you look at the adjusted rate of CHEST score of 4 in the panel, so Dr. Kannan, can you point to the adjusted rate? Then you will have a score of 4% per year. That means that if I see 100 patients today, next year, 4 of them will get a stroke. Then in 10 years' time, 40 of them will get a stroke. So that is very high risk. So yes, anybody with CHEST of 2 and above in male, looking at the left guideline, look at the adopted from ESC, if you have a high stroke risk, which is CHEST of more than 2 in males or more than 3 or more, in female, then the oral anticoagulation is definitely warranted. Class 1A recommendation. Now, nowadays, if I see even patient with moderate stroke risk, CHEST of 1 in male or 2 or more in female, 2, I would personally also advise for oral anticoagulation, especially the novel oral anticoagulation. Now, remember, this guideline is designed for global use. So some of the third world country may not have the privilege like us using NOAC. So of course they cannot warrant everyone with CHEST 1 get a NOAC. So I think with NOAC, which is safer than warfarin, those with CHEST 1 in males, 2 in females, I would also counsel them for them to actually getting this drug to protect them from thromboembolic event.
Thank you, Dr. Koh.
Yep.
What anticoagulations are currently available, and what would you recommend?
All right. So now, in Malaysia, we have the luxury of all novel oral anticoagulation. Edoxaban is just on board early this year. So now we have dabigatran, which is a factor 2 inhibitor, and the factor 10A inhibitor will be the rivaroxaban, apizaban, and edoxaban. Now, to be honest, we can use either all 4 of them. All 4 of them have a good efficacy in preventing stroke and systemic embolism, and also have safety data that the risk of bleeding is at least same or lower than warfarin. Especially in Asian, the risk of bleeding in warfarin actually is very high, higher than those on NOACs. So all of the NOACs can be used. Some of them are twice a day. For example, dabigatran and apizaban is twice a day. rivaroxaban and edoxaban are single daily use. So if the patient preferred to take once a day medication, then perhaps the rivaroxaban and edoxaban would be a suitable choice for them. But if the patient already have other medication that requires BD dosing, so they don't mind taking twice a day dosing, then dabigatran and apizaban is also a good choice. Now this is a bit more how is it? Sometimes I will sub-select some patient based on data. For example, if the patient has history of thromboembolism before, like your earlier patient with a gangrenous leg, that means that this patient has very high risk of getting another thromboembolic event. Then perhaps the data that favors the superiority of NOACs compared to warfarin is the dabigatran 150 milligram twice a day.
Okay, thank you. So is there a role for warfarin at all?
I've not been using warfarin for the past maybe 10 years, except for patient with a mitral prospecting valve, patient with end-stage renal failure. Only these two patients I use warfarin. The rest, most of them, I think for safety-wise, NOACs is still preferred, and it is in line with the guideline.
I suppose cost is also a consideration because these direct-acting anticoagulants are far more expensive.
Correct.
Yes. Thank you, Dr. Kong. Would an antiplatelet agent like clopidogrel be sufficient? Maybe we could ask Dr. Choi.
The treatment for stroke prevention in atrial fibrillation, I guess most of the trials have been quite consistent. We need anticoagulant in order to prevent stroke. But if you were to have to choose one antiplatelet in replacement, I think there are also a couple of trials to indicate that between aspirin and clopidogrel has a higher efficacy in preventing embolic stroke. But the short answer is, I think anticoagulation is still the mainstream of treatment in preventing embolic stroke in the air.
Thank you, Dr. Choi. Dr. Choi, this patient had a past history of gastrointestinal bleed and so is worried about anticoagulation treatment. Is there any alternative treatment?
Yeah, so this is actually a very interesting question. I get that a lot in my clinic. So patients will be asking, how do I get embolic stroke when I have atrial fibrillation? So I remember my anatomy professor used to joke, our left atrial appendage is an appendage, just like our appendix. So we don't know why it's there, but it is there. You can remove it, probably nothing will happen. So the anatomy of the left atrial appendage is actually the pectinate musculature. So it contracts during sinus rhythm. So that's why even when you have the slightest blood at the base of the appendage, it will be emptied during sinus rhythm. However, when you have atrial fibrillation, there will be stasis of blood and coupled together with increased left atrial pressure. That's how you get clot forms in the left atrial appendage. That comes to my my next explanation regarding left atrial appendage occluder. There are a couple of brands, for example, Watchman and etc. So that can be considered in patients with massive GI bleed, life-threatening GI bleed, and they cannot take anticoagulation because of that. And LAA occluder can be considered in replacement rather than giving them anticoagulation. However, we must also understand there are a few caveats. Not all strokes come from the LAA, so it's not that putting in a LAA occluder, the patient will not get stroke. And even after implanting LAA occluder, the patient has to put on immediate anticoagulation as well, warfarin and dual anticoagulant, in order to reach an endothelization of the occluder. So, yeah, that will be the alternative treatment for this patient.
Thank you, Dr. Now, this patient then continued to be well. On the 11th of March, about a month later, during a routine follow-up, she remained asymptomatic and well. Then I commented to her that her pulse was now regular, and the ECG confirmed that she was back in sinus rhythm. So she was very happy, and she said, I want to stop anticoagulation. What would you advise this patient?
I would advise the patient to continue with the oral anticoagulant because her CHEPS score is quite high. So even though she is now back in sinus rhythm, there is a good chance that the atrial fibrillation may recur, and during that prolonged episode, she may actually develop embolic stroke. That's why even though she has sinus rhythm now, the role of an long-term oral anticoagulant is still required for this patient.
Okay. She has also heard of radiofrequency ablation for atrial fibrillation. Is there a role for this treatment for atrial fibrillation in this patient?
The short answer is yes, because she's still at the early phase of AF, proximal AF. Even though she denies any symptom when she had the DAF, I find it maybe a little bit difficult to believe. Sometimes because the patient hasn't really exerted herself much enough to actually experience the absence of symptoms. So I would still offer AF ablation for this patient because the recurrence rate should be quite low in her, and at least recommended for the patient.
Okay, Dr. Choi. Okay, in the interest of time, let's move on to the next case. This patient has been known to me from 2005 when he was 35 years old. He had hypertension and hyperlipidemia. Over the years,
A bit unstable, it's not a Wi-Fi. Okay, go ahead.
Now, the subsequent illnesses that he developed over the years were diabetes mellitus and esophageal reflux. Since August 2016, that's about 11 years after I first started seeing him, he complained of intermittent palpitation. Now, in the social history, he smoked and he consumed alcohol several times per week. A clinical examination revealed that he was obese, especially around his tummy, extraperitoneal fat. Blood pressure was 130/80, pulse rate 68 per minute regular. Examination of the heart and lungs was clinically normal. In the abdomen, he had what appears to be an enlarged fatty liver. Investigations done revealed that the chest X-ray was normal, echocardiogram was normal, and the treadmill test repeatedly was normal. And these were a list of his medications. Dr. Choi, this patient complains of intermittent palpitations. My clinical examination is normal. The 12-lead ECG is normal. What investigation should I do next?
Okay, so this patient has a couple of features good enough for me to suspect possible atrial fibrillation. He's overweight, he's looking at BMI, and given the history of alcohol consumption and also the underlying risk factors of diabetes and dyslipidemia, it's crucial for us to figure out why he had the palpitation. Of course, when he comes to the clinic, his pulse is regular, ECG is going to be normal. So we need some kind of a monitoring for him to bring home. So those days we used to put patients on 24 hours Holter monitoring, which can be quite cumbersome. You put them on wires and you hang, little recorder around the neck. The patient will not be able to move around much, and sometimes they actually shower and the whole thing gets spoiled. Luckily nowadays we have better Holter monitoring, and it can just be like a stick-on thing you put on the chest. It can go from 3 days, 7 days, or even up to 14 days, and that is good enough to detect the intermittent palpitation that he had, and hopefully that will give us an idea. And I would like to spend just a couple of seconds to mention that if the patient happened to be using an iWatch, which is actually a watch from Apple, not that I'm promoting iWatch in any way at all, but because iWatch has an algorithm that can actually detect the irregularity of the heart rate, and if it's too irregular and it feels that it's probably atrial fibrillation, it can alert the patient. And I can assure you that the accuracy is quite good. So if the patient happens to be using an iWatch, I would just say, just switch on the iWatch irregularity rhythm detection, and that will be also good enough.
Thank you, Dr. Choi. Now, This patient has a Holter done, and can you interpret the Holter first, Dr. Choi?
Okay, so looking at this page of Holter recordings, the one in the red circle shows that this segment is actually sinus rhythm. You can see a very nice P wave followed by the QRS complexes. And then the green color circle shows that this is actually atrial fibrillation. As you can tell, it's fast, it's irregular. There's no P waves with fibrillating waves in between. And the yellow circle shows a very interesting event. So for EP, we always love to see what initiates the event rather than in between. So between the red, yellow, and green, I'm sure the co agree, the yellow one is the one that intrigues us most. So you can see very clearly the one in the yellow circle. There's actually a bit, two bits actually looks broad, and it initiates the AF. The broad bit, of course, could be a PVC or could it be a aberrancy, but if you look at it carefully, you can actually see a P wave just right before the broad bit. So these are actually PACs, atrial ectopics, and it's quite clear here that the atrial ectopic actually initiated the atrial fibrillation, and this will be a good case for ablation, in fact.
Thank you, Dr. Choi. So I added bisoprolol 2.5 milligrams and also a direct anticoagulant rivaroxaban. We also told him to cut down his alcohol intake, and it became symptomatically better. From January of 2019, he complained of more palpitations. The doctor was now a medical student, and she noted that the patient increased his alcohol intake to almost daily. And with increased alcohol, there were more palpitations. During this clinic visit, I noticed that his heart rate was 72 per minute and he was in atrial fibrillation. Dr. Cole, the question is to you. Is there a relationship between alcohol intake and atrial fibrillation? And what are the management options at this time?
Yep. Of course, I think it has been well known that alcohol is toxic to our body, especially two organs that are very sensitive, which is the liver and also the heart. If you consume enough alcohol, it may cause a liver cirrhosis and also alcoholic cardiomyopathy. And you can see that as one of the cause of the AF is actually alcohol. And do we have any evidence on that? If you stop alcohol, your AF is going to get better? Definitely. So the group in Australia, they have did a lot of study on lifestyle intervention to reduce burden of atrial fibrillation. One of it, very very famous one, is the obesity. If you're able to reduce your weight, you are able to reduce the burden of atrial fibrillation. And this is another lifestyle intervention kind of study that they've done. That if you are abstinent for alcohol for 6 months, so you can even see the effect very early on in the first 6 months, then you're able to reduce the atrial fibrillation recurrence. So for this patient, we have to advise, of course, the management is very simple. Stop your alcohol. If the patient said 1 glass, 2 glass can, no, you have to complete abstinence. And we know that alcohol is associated with all this autonomic modulation, reduced heart rate variability, sympathetic effect, and we know that sometimes they go for binge drinking, which is associated with all this cardiac inflammation. So the answer is very straightforward: is no. It's whether you're able to motivate the patient to do that or not.
Thank you, Dr. Kong. So we counsel the patient to stop or drastically cut down his alcohol. We added flecainide, 50 milligrams twice a day, and this, he said, he symptomatically felt better. Dr. Ko, what is flecainide? Can this drug be used for all patients with atrial fibrillation?
Okay, great question. Now, flecainide is a type of anti-arrhythmic drug. So I hope you all can remember that in medical student we have this classification. We call it the Bougainvillean classification of anti-arrhythmic, class 1, 2, 3, 4. And flecainide belongs to what we call the class 1 C of antiarrhythmic drug, we act as the sodium channel blocker. Can you see the first column there? That's the action potential of our cardiac cell. Now, basically, what most antiarrhythmic do is to stabilize the membrane, and particularly flecainide works very well in patients with atrial fibrillation. Now, but what I want to caution everyone is, flecainide is not suitable for every case, especially patient with ischemic heart disease and structural heart disease with poor LV function. Now, last time, many years ago, I think everybody had been using antiarrhythmic drugs without screening the patient. We thought everything is all the antiarrhythmic drugs is safe. When the CAST trial is during your time, Dr. Kannan, somewhere in the early 90s, I think. There's CAST1, which they use encanite and also flecainide in patients with post-myocardial infarction with PVC. They want to reduce the PVC because they think that the PVC is causing more problem. And the result was the PVC was reduced, but the mortality is so high they have to stop the study. So the sudden cardiac death, arrhythmia, poor arrhythmic, they require shocks, so they have to stop the study. Then CAST2 came out with another drug, I can't remember the name, I think it's morisizine, also another class 1C drug which has been withdrawn from the market. The first 14 days when you use the drug, also same thing, increased risk of death. So far, I think if you want to use the class 1C drug, make sure the patient is not having a post-MI, the patient has not significant coronary disease, no structural heart disease. So even patient with significant left ventricular hypertrophy, I'll use it with very caution. So, but it is very safe in patient with normal structural heart. What we say, how do you classify normal structural heart? Echocardiogram normal, no history of coronary disease, and then generally it's quite safe to use this drug, and it's quite effective. Yeah.
Thank you, Dr. Kong. The patient was compliant. In July of 2019, the patient was compliant with instructions to completely abstain from alcohol for 2 months. So we repeated the 24-hour halter after the alcohol was stopped. And this is his halter. And Dr. Cole, can you interpret the 24-hour halter, which was done after he abstained from alcohol for 2 months? And can you also tell us what you did next? Because at this point in time, I think I referred him to you.
Okay, good. Now, if you look at this halter, the first row, second row, and the third row is done, it's during the sleeping hours because it's like 3 a.m., 4 a.m. Now you can see that it's a normal sinus bradycardia, so there's nothing exciting there. But when it's near waking up, you can see there's a bit of PAC, the third row. You can see that the third row, PAC, and it triggers a short run of atrial tachycardia. You can see that. Now, look at this short run of we call it a non-sustained SVT or non-sustained atrial tachycardia. It's very irregular. It means that actually the atrial is firing very fast, conducting through the ventricle at different rate because of the AV nodal refractory period. This tells us that this patient has a trigger from the atrium. Now, based on the previous halter, patients also have a lot of these atrial ectopics. I'm very excited to see this because we know once we see this, we can identify that this patient has a trigger somewhere from the atrium. And I usually will go to hunt for this trigger because if you can find the trigger, which is usually the atrial ectopic that hides somewhere in the pulmonary veins or the left atrium, if you find the trigger, you ablate or terminate the trigger, you can cure the atrial fibrillation. So I think the patient, despite having abstinence for alcohol, perhaps the atrial has also a bit enlarged. Patient is still obese. I think the patient has done a lot better from previous when they consume more alcohol. Now it has cooled down, but the thing is remain. That's why I think I counseled the patient for AF ablation, and the patient agreed because they were so symptomatic despite have to stop the alcohol, have to take medication. They're still having this palpitation. So what I did is we went in and we found a trigger somewhere in the left carina region in between the two pulmonary veins. I identified that, isolate that, and the patient, I think, became very well after the procedure. So perhaps we can maybe show some of the AF ablation, the 3D images, maybe in the next session, our second session.
Thank you, Dr. Koh. I think we are running out of time. We will meet next month for part 2 of our atrial fibrillation. Please join us. There are more exciting things to share with you. Thank you once again for joining us.
Okay, question time now.
Do we have time for questions?
Yeah. I think there's one question from Dr. Ng Cheng Huat here. When do you stop NOAC before elective surgery, and when do you restart the NOAC after elective surgery?
Okay, so I guess it depends on the renal clearance of the patient. I would say, generally speaking, it should be 24 hours before the surgery. If the patient has renal impairment and the dose has been a bit higher than expected, maybe up to 48 hours before the surgery. When to restart back, for me, it always depends on the surgeon. It depends on the post-op bleeding scenario. If the patient is still bleeding, we can't stop. In that case, probably I would consider putting them on something like Taxane and enoxaparin, if allowed, before putting them on NOAC. What about Dr. Koh? What do you think?
Yeah, you're right. So basically, I think I have to look at just two things. Troy mentioned depends on the renal clearance. That's number one. That's very important. Number two, actually the type of surgery. Now, if you have a very minor surgery or minor procedure, for example, like dental scaling, maybe choreangiogram, you have some superficial injection or something like that. Some of us may not even want to stop any of the dose, or if you want, then stop one dose. If the surgery is more complex, a very high risk surgery, so in general you stop a bit longer. And it's a normal surgery that perhaps what Troy said, stop like 24 hours at least. But that all depends on the renal clearance, because all of the NOACs excretes through the kidney, through the kidney. And of course, some of them are more dependent on renal clearance, for example, like dabigatran. So in general, anything, if you have a normal renal function for a normal procedure, normal risk procedure, then anything 24 hours should be safe. If you have a bit of renal impairment, then you might need to consider stopping a bit longer, like 36 hours or 48 hours. Restart the procedure also depend on the type of surgery. Some surgery have potential bleeding and then cause problem. Neurosurgery, spine surgery, then you want to restart it a bit later, about 48 hours later, or depends on the surgeon's instruction. And most of the minor procedure or normal procedure, like for example, appendix surgery, what else? Gallstone, you can start the NOACs maybe after 24 hours.
Thank you. Any more questions?
I just have one. To ask the cardiologist, since NOACs all renally excreted, and in terms of safety profile, we should be looking at the renal function. Down to what level of creatinine clearance do you all, as cardiologists, feel comfortable to use NOACs, and do you have a preference for which particular NOACs?
Good question. Maybe I start first. For me, I guess it depends on the approval. For instance, you can see different NOACs have different level of creatinine clearance approved for the usage. For instance, apixaban, if not mistaken, correct me if I'm wrong, in the United States, they even approve it for dialysis patients, 2.5 milligram BD. But I don't think we have that kind of approval in Malaysia yet. So, because I think to them, they feel that this is safe even for dialysis patients. So my counterpoint depends on the type of NOAC that I'm using as per the up-to-date allowance. For me personally, it also depends on whether the patient has any immediate risk of bleeding. If the patient has an immediate risk of bleeding, for example, something that the patient might need a reversal very quickly, then the choice of NOAC with the reversal agent would be desirable as well.
Would the availability of a reversal agent influence your choice?
No, the answer is no, because I think every agent has their pros and cons. So I don't think the availability of the agent will determine the usage.
Okay. Just some questions from curiosity from the hematological point of view.
What is your opinion, Dr. Alan?
I don't want to make any comments at this stage because it's a little bit sensitive to particulars to go for. Maybe part 2 we can discuss more about it.
Dr. Kanan, what's your opinion?
I think a little more to add from Choi has already said. Yeah.
Okay. Any other questions? Please ask in either Facebook, DOPS Facebook group or YouTube in the comment section, or else Slido. I noticed there are no questions from Slido, so I won't show the Slido. It's just about 3. So, Mr. Moderator, should we show the QR code for?
Yes, let's do that.
For points, yeah? Okay. I hope the stream quality was okay, because I think our Wi-Fi was a little bit unstable. Let me... Okay, you all should see the QR code now and can take the MMA app and scan. I hope it works out for you. So the QR code will be valid for about an hour, and unfortunately after that you can't claim the points. So we hope that you enjoyed the session. There will be part 2 on atrial fibrillation. And I think there's probably some interesting new ways to treat next month.
We've got another interesting and different type of case history, and please join us. Have a nice weekend, everyone.
Okay, I'll leave the QR code on for a little bit more. Then after a minute or 2, we'll stop the stream. But in case it will always be on YouTube, so you can go to our YouTube channel and rewatch the talk. Okay. There's a comment from Dr. Sukdashan that his line wasn't very good. So whatever we live stream here will always be there. You can rewatch it again. Okay. And if you have questions, you can ask in part 2 when we have it in May. We probably plan to do it in the 2nd week after Hari Raya.
Yes.
Okay. So I'm going to just leave the QR code on, and after a minute we'll end the stream. So thank you, everyone. Thank you.
Thank you.
Thank you.